So, hi, thank you for the invitation. I'm very pleased to be here. The first thing to say is that since I was asked by the head of our department in medical oncology, the sarcoma unit, to come here, something has changed, and I'm soon going to join the department again as a locum consultant, which is very good for me. So no more a specialty registrar. So I've been asked to talk to you about clinical trials and latest developments in GIST. So as you can imagine, there's a lot to say, but I thought I will start from some basics and then I'll move on to what's new. So this is a very basic plan. I'll very briefly touch upon adjuvant treatment and then talk about metastatic treatment and some of the drugs that are being used in current clinical trials, which is really what will be the future in terms of treatment of the disease. So the reason I thought I'd start from this is because obviously it's very difficult and never a good idea to start a story from the middle. So very briefly, when we talk about localized GIST, the mainstay of treatment is surgical resection. But what's really important is that even with a complete surgical resection, about 50% of people with the disease with complete resection will not be alive at 5 years. So hence, thank you, the importance of giving adjuvant treatment. Adjuvant treatment in simple terms means treatment that you give following an operation. So treatment to prevent recurrence of a tumor. So there have been a few trials that have shown that using imatinib, which is the most widely used drug in this disease, can prevent recurrence. And there are a few terms here that you might not be familiar with. So the RFS is recurrence-free survival. And what has been shown is if you give imatinib, you reduce the chances of GIST coming back a year after surgery. And this diagram shows pretty much the same, but going on for longer, up to 4 years, that if you use imatinib after complete resection, you do reduce the chances of a GIST recurring. So there are certain criteria with which we use to choose who will have the adjuvant treatment. These have changed a bit over the years, but these have to do with tumor size, with a mitotic count, which in effect shows how aggressive the tumor is, but looking at specific characteristics under the microscope, and then combination of those. Another thing that which is very important, which is irrespective of what the tumor looks like, is whether within surgery there was tumor rupture. So whether when the tumor was removed, whether any of it spilled over really in the surrounding area, because that also makes it high risk for coming back. Something which happened a bit later on in subsequent trials was to try and look at the duration of treatment. And this is always one of the big questions with any treatment, really, how long do you go on for? And what has been shown in terms of recurrence-free survival, which you see at the top, but then overall survival, is that if you give treatment with imatinib for 3 years rather than 1, people overall do better. Now, this is quite complicated, but this is trying in only one slide, because this is not the focus of my talk, to try and summarize what the standard treatments are for what is called advanced disease or metastatic disease. So to put this in very simple terms, at the moment the first line treatment is imatinib, and there are some issues in terms of the dose, in terms of looking at the molecular profile of these tumors, which is really, really important for diagnosis but also for treatment. There are certain mutations that do require higher doses of imatinib, even as first-line treatment. Subsequent to that, if somebody on imatinib shows evidence of disease progression rather than improvement, second-line treatment at the moment as standard is sunitinib, and then third-line treatment is regorafenib. So at the moment, these are the 3 standard treatments given at the metastatic setting. Now, sometimes, which is quite rare, these treatments are given not because of disease progression only, but also in cases where one of these is not well tolerated. In terms of new treatments, there are quite a few new and exciting treatments for this disease, and this is the focus of this talk. In terms of these, I'll start with the one that we have looked at quite a lot, that Errol Marsden, and has been also used in many clinical trials so far, and that's called BLU-285. As you might know, lots of the new medications that come out, at least at the initial phase, before they get licensed, only have a combination of letters and numbers as their names, which makes them quite complicated to remember. So This is a drug that is used to inhibit KIT and platelet-derived growth factor receptor alpha. Now, this is exactly what imatinib does, but this medication is thought to do it in an even more potent and effective way. Something that this slide is trying to show, which is hopefully clear, is that if you look at the first column, it shows that for different kinds of mutations, because one of the things that is always very important when we talk about GIST is the mutations that make up the tumor. And life is quite a bit more complicated than that, because often we talk about a gene mutation, and for example, we'll talk about a KIT mutation, but that's not only one thing. So having a mutation in one gene doesn't mean that everyone will have the same kind of mutation. In fact, there are many different kinds of mutations, and some of them mean that someone is more likely to respond to a certain drug, and sometimes a mutation makes it less likely that they will respond. And that's something that we've got a lot of experience on using imatinib. So in this case, what this slide is showing is that with imatinib being on the far right, you need a much higher concentration of the drug to inhibit those receptors, so to inhibit those mutations on KIT and at the bottom of the platelet-derived growth factor receptor. The reason why this is important is because, of course, with any drug, we're very interested in its side effect profile. So if you need a higher dose, if you need to achieve a higher concentration within the blood, you're more likely to give toxicity. Whereas if you're using a much lower concentration, you hope that that way you can avoid unnecessary toxicity and at the same time achieve efficacy. Now, this is the phase 1 study that was done in order to investigate this medication, the BLU-285. Now, very briefly about phase 1 trials. Phase 1 trials are the first in-human trials that are done, and the aim of such trials is not to work out how effective a drug is. The aim of such a trial is to establish the dose for subsequent trials, but also to look at safety. However, there are many different kinds of phase 1 trials, and very often when there's a reason to believe that a specific drug will work, so when there is a target as it's called, and in this case there are very specific targets which are mutations on KIT and a platelet-derived growth factor, you have quite a bit of confidence that once you've established the safety and you've got the right dose, you know that this is very likely to be effective in the tumor type that you're talking. The reason I say this is that there are other phase 1 trials that do not have such a specific target. Therefore, the scope of those trials is quite different. Now, in this case, there was a very good rationale behind giving such a drug that blocks these receptors, and therefore they divided the first cohort of patients that was treated into 2 different groups. The first one was patients with GIST that was unresectable, and they had had imatinib at least, and then also any other subsequent treatment. So it wasn't only confined to those that had at least 3 lines of treatment. In certain cases, you could only have had 1 or 2 or 3 or even more lines of treatment. The other group was patients with a platelet-derived growth factor receptor alpha specific mutation, which is the one you can see here, the D842V. And the importance of this mutation and the reason this was specifically targeted is that although imatinib does work on the platelet-derived growth factor receptor mutations, this specific kind of mutation causes resistance. So we know very well from also the adjuvant setting, but also from the metastatic setting, that if someone has this specific mutation on their tumor, then they are a lot less likely to respond to imatinib. Hence, the rationale behind this was to find a subgroup of patients that we know already do not do very well with what is standard first-line and second-line treatments. Now, what this slide is showing, perhaps the most interesting part is at the very bottom, where the 2 cohorts of patients, the ones with KIT mutations and platelet-derived growth factor receptor alpha mutations, the number of treatments they had previously. And what's really interesting to see on that is that the patients that had had KIT mutations had been treated with a median of 4 different lines of treatment. So on average, they had already had 4 different drugs before going onto the trial. So this was the 5th drug or beyond that they were having. And in fact, there was a large proportion that had over 3. So 67 of the 87 patients in that cohort had already received 3 or more different drugs. And again, the reason why this is important, and it's important in real life, but also important in the context of a trial, is because what you are saying is I've got a drug that works in a very similar way to another drug that I'm already using. So the question is, why is this more likely to work? So in this case, you know that by giving it in patients who have already progressed on a treatment that targets the same receptors is very important. It's not that you're giving it to somebody who's never had such a treatment before. Now, what this diagram is showing, and hopefully I can make it slightly simpler for you, is that the line in the middle shows what happens if there's no change in the size of the tumor. Anything above the line means that the tumor has grown in size, and anything below the line means that it has gone down in size. Now, something which again becomes very complicated when it comes to assessing response in day-to-day life, but also in trials, is the importance of what is called stable and what is called progressive disease or response. And very often there are such discussions in clinic, because when we say stable, sometimes we mean a bit bigger, sometimes a bit smaller. So sometimes when somebody reads a report, it's not entirely clear why we've called it stable. So there are specific criteria with which you can call something bigger or smaller, so progression or response. And that refers that for something to be called progression, it needs to be 20% above the original size. Whereas for something to be called response, you need to have a reduction that is 30% or greater than that. So if you have a tumor that has decreased in size by 25%, so by a quarter, strictly speaking, the main criteria used to assess this means that it's stable. It's on the good side of stable, but it's still called stable. Going back to this specific diagram, at the very, very top, there is a summary. There's on each individual the kind of mutation that they had on KIT. And although it's very difficult to see because it's quite small, the very interesting point about this slide is, first of all, 67% of patients did show some tumor shrinkage, so they are below the line rather than above, whether this is within the remit of stable disease or progression, and a third didn't and instead progressed. But what's also really interesting to show is that there are cases where we have individuals with exactly the same mutation, but some responded and some progressed. So even with our increased understanding of how these drugs work, even looking at not simply which gene is mutated, but the very specific gene mutation that we're talking about, and giving the same drug, you don't necessarily have the same kind of response. And that, of course, has always been the focus of all research, to try and tease out why this is the case. So it's not simply giving numbers and say 2 of 3 patients respond or 3 or 4 respond. It's also trying to understand why some do and others don't, when otherwise what you've seen at the molecular level even is pretty much the same. So this slide is showing something quite similar. In effect, in this trial they found that on this heavily pre-treated population, so with patients that had received multiple lines of treatment, when they received this drug, there was a median progression-free survival of 11.5 months. What that means, progression-free survival, is how long you go on from starting that drug to showing any sign of progression. And again, progression is, as defined from what I told you earlier, an increase in size by more than 20% from that original. So this is really important here, because what it shows is that after all these lines of treatment with this new drug, it took about a year as a median. So some people before, some people after that, but the median was about a year during which there was no progression of the disease. And that's quite important. Now, this is the second cohort of patients that was looked at in this study, and this is the resistant mutation I talked to you about briefly earlier, the platelet-derived growth factor receptor alpha. And again, the reason why this was looked at specifically was because this is a kind of mutation that normally, and certainly in the past, would be considered a very bad sign. It would be a bad prognostic indicator, because we know that imatinib doesn't really work on these mutations. And here, what is quite remarkable is in that this group of patients, which is quite small, it's only 31, everyone showed a degree of response. Again, some remain within the limit of stable, but the majority did actually show a significant tumor shrinkage, which is very, very important. And that was one of the things that this drug was trying to show and achieve. In this group, the progression-free survival I was talking to you about earlier wasn't even reached during the time of this study. So that means that there wasn't a median in terms of how, when they were looking at these patients for the duration of the trial, they didn't get a median progression-free survival. And in fact, at 12 months, 78% of these 31 patients still hadn't progressed. And that, of course, is very important too. Now, something which, of course, is always very interesting and very important, because it's all great to say that we've got a new drug and that drug can work well, especially in a subset of people. The question is, what toxicities does it give and what side effects do people get? The first thing to say is that in lots of phase 1 trials, the main way with which a dose is determined for any drug is the kind of toxicity that you get. So this here was based on a cumulative toxicity on all the patients that took part in this study, which means that hopefully when we go on to the further trials at phase 2 or phase 3, this will not be as severe because the dose will be such that we'll avoid getting the grade 3 or grade 4 toxicities. Now again, to briefly explain to you what these gradings mean. Now these gradings are based on some international criteria, and they have to do with specific criteria. There are extensive tables that show whether this is a blood test abnormality or whether this is a symptom. There's a way of grading it using those criteria, and the reason these exist is so that people across the world, health professionals and patients, can understand the same thing when they grade a specific change. So a very simple example, for example, is anemia. It's easy to say that somebody dropped the hemoglobin, and you can say that this was evident in the patient, so they had symptoms or not, but that doesn't really communicate the severity of that. So for all the ranges of hemoglobin, anything from normal or below, there is a specific grade given for the purposes of understanding. Now, what is important about this is that when we talk about grade 3 or grade 4 toxicities, usually that means that at that stage, when you have developed such a toxicity, that somehow is limiting a patient's lifestyle. So whether it is tiredness, whether it is, for example, in terms of nausea and vomiting, that is interfering with their activities of daily living. And again, there can be discussions as to how you can determine what limits somebody's activities of daily living, because people live different lives and they've got different responsibilities. Within the limits of this grading system, this is what this is trying to achieve. Because again, obviously, when we talk about tiredness, when we talk about sickness, it isn't whether these symptoms come on as a result of the drug. The question is, what can you do to deal with them and how they interfere with somebody's life despite our efforts. Because if you're giving a drug that you can say can help and can actually shrink a tumor, arguably you don't want to impair somebody's quality of life to the extent they can't get out of the house for whatever reason. Now, looking at the specifics here, one of the main toxicities was tiredness and anemia, so drop in hemoglobin. A low phosphate, which also came next, is something which is very rarely something that causes symptoms. And the same way that with anemia you can give a blood transfusion, with a low phosphate you can replace that either intravenously or orally. So some of these can easily be dealt with even if they come on, even if they're quite severe. Fatigue is also very important, and the main issue about fatigue is that although there are so many different reasons why one can be fatigued and tired, there isn't an easy solution to it. So we often say that it's multifactorial. There are things that we can correct, like anemia, but fatigue overall can be very overwhelming, and it's very, very difficult to deal with because there isn't a drug for it. There isn't a solution. There are things we can do for diarrhea, things we can do for sickness. So here, that was a 7% of cases where this was quite significant. Something else to note, and this is something which is quite different to drugs that have been given before in this setting, is what is highlighted as cognitive effects. Somewhere near the middle of this table, and this has to do with memory impairment or concentration impairment. And the difficulty with this is that it's very difficult to grade, especially as different people will talk about this in a different way, or they'll be affected in different ways. But this is something that has been highlighted, and it's really important, and there's a lot of effort into trying to understand why, and also be better at understanding the severity of this. Now, moving on to a different agent, DCC-2618. So this drug as well works in a very similar way to the one I've just spoken to you about. One of the main reasons why it is thought that this is a very good drug in this setting is because it has been shown in the lab to be very effective at blocking mutations both in KIT and platelet-derived growth factor receptor alpha, and do this even in mutations that so far have been thought to be resistance mutations. So whether the ones that initially mean that imatinib, for example, is not going to work, but also what we know is that when anyone who is on treatment with imatinib or any of the other treatments will often develop further mutations in these genes, and these are called resistance mutations. Therefore, there's a change in the mutation in the tumor that means that the drug that previously worked doesn't work anymore. So it is thought that this drug is very good at blocking all these different kinds of mutations, even the ones that are linked with resistance, whether prior to any treatment or following previous treatments. So this refers to again the phase 1 study that was done to look at this medication. What is very interesting here, and that's again a very important principle of certain trials, is that the patients that were targeted weren't only patients with GIST. This trial looked at anyone whose tumor, regardless of where that was from, had this mutation profile. So they looked specifically at mutations in KIT and platelet-derived growth factor receptor. As is very often the case with such trials, somebody needs to be very fit to go on them, and this is what, and you've seen this before, refers to this ECO-GO performance status of 0 and 1. So you need somebody to be quite fit when they start treatment, because if they're not, then it's very difficult to understand whether your treatment is likely to work or not. And of course, the usual parameters that we look at in blood tests, etc., etc. So I'll start with side effects this time, as this cohort of patients had quite a different side effect profile. And here we had people who developed hypertension. They had an increase in the lipase levels, which is often linked with pancreatitis, although there was never any evidence of pancreatitis on imaging. But this increase in some cases was significant in that it was so high that the drug had to be stopped. And that also goes for creatine kinase increase, which is usually a muscle, an indicator of muscle breakdown, that also went up. And it hasn't been clear whether this was linked to the actual medication, but again, because of the severity of that, sometimes the medication had to be withheld and wait for this to come down before restarting. Again, issues like anemia and fatigue, like with all these drugs, can often be reasons why somebody either stops treatment altogether or sometimes has breaks. Now, on some more positive news with a few pictures, what you can see at the bottom right is 2 images from a PET scan from the same patient. What you see lighting up as black on the left, the baseline, is areas of disease within the liver, and then on the right, after only 1 cycle of treatment, these are now not visible anymore. Again, I don't know whether you're familiar with PET scans. They are not simply showing the site of a tumor, but they also show its what is called metabolic activity. We often call them hot or cold. So in this case, more black is more hot and white is cold, and that reflects tumor activity. So in this case, which of course is well chosen to show this very well, there was a case where there was quite a lot of disease that was active, and after only 1 cycle of treatment that went. What was impressive about this trial is that there was response in quite a large number of patients. So 14 of the 15 that had KIT mutations, and that's all sorts of KIT mutations, did respond to the treatment. And that was based on CT scans, so tumor shrinkage, but also 13 of 15 showed that on PET scan. So there was reduced metabolic activity within the tumors following treatment. Now, again here at the top, there's just an example of what on the left was the tumour at baseline, which is quite large, and then following 2 cycles of treatment, there's quite significant reduction, and you don't even need to measure that, you can just see by eye. Again, patients that had had quite a bit of treatment before that, with this new agent, a lot of very significant tumour shrinkage has been achieved. What is there at the bottom, and I thought it's interesting to include this just to make the point I tried to make earlier, is that this is a patient with a brain tumour, so completely different to GIST. This wasn't a case of GIST that travelled to the brain. This is a completely different kind of cancer, a glioblastoma. And in this particular trial, because they included patients that had such mutations in the tumour, showed that somebody with a glioblastoma that did have mutations in platelet-derived growth factor receptor and KIT, and some extra mutations, responded extremely well to the same treatment. And as you can see on the left, there is this quite large area that appears to be quite white within the brain that following treatment shrunk and then almost disappeared. And again, this is very, very important in this context because this is a proof of the principle that these treatments are targeting specific mutations. So this is not just about a specific tumor, this is looking at the molecular level. One could ask, and why are there other tumors that have the same kinds of mutations? This is something we don't really know. There are tumor types that are completely different in terms of site, in terms of clinical activity, that do share common mutations. And very often at this setting, so at initial trials, one targets not the kind of tumor, but targets the mutation. And sometimes with very good results, as you can see here too. So in terms of efficacy, I already went through this quite briefly. There was quite a lot of tumor shrinkage in the majority of cases. There were some patients that were heavily pre-treated, and they also showed a very good response. And that wasn't only the case in the majority of people who took part in this who were with GIST, but also with other tumor types like the glioblastoma you saw in the previous picture. What this slide is trying to say is that, again, something which is very interesting, and it's very relevant when we talk about this, because, you know, if you look from the outside, for most people, GIST is just a name. In fact, the majority of people who haven't had either themselves or a relative with this will not know what GIST is. But of course, if anyone is somebody who has got it or is a relative, will know that GIST is not one disease, and this is true for all tumors really. And because we always talk about the molecular profile, what's so interesting to look at in these trials is the different types of mutations. And here they did look at the different types of mutations that people had when they went into the trial, and what again is really important is that across the range of mutations that was included, there was response in patients that had all these types. Again, talking about toxicity, I've already mentioned this. The main toxicities were the increase in lipase, which is sometimes showing pancreatitis, although it wasn't in this case. Anemia, that in some cases did require treatment with blood transfusion, and high blood pressure, that in the majority of cases resolved by having a break in the treatment. In other cases, it was with an antihypertensive medication. Now, I've included this diagram to make another point which is very important, which is when we talk about drugs, we often forget that one of the main things about any treatment is not simply whether it works or not and the side effect profile, but also the dose. And I mean, these are questions that we've asked with other drugs, also with imatinib, for example, the 400 versus 800 milligram dose. In this case, what this is showing is that they tried a range of different doses. And again, below the line means response, above the line means progression. The blue columns show patients who had treatment with less than 100 milligrams of this drug, and then red was above 100 milligrams. And the reason why it's either red or blue is just to simplify it and not show the whole range. So what we can see here very simply is that everyone who had below 100 milligrams did not respond, whereas the ones that had above 100 milligrams once a day, some responded and some didn't. But certainly if you gave what appeared to be a suboptimal dose, no one responded. And again, this is very, very important to note, and this is something that is often forgotten when drugs are used at subsequent phases in terms of trials. So this is a diagram showing the progression-free survival, and again comparing the different doses, which is what I showed you in the previous one. Anyone who was treated with above 100 milligrams once a day did a lot better than if they were treated with a lower dose. Something to say is that after this trial, the dose that was established as the one to be used forward in subsequent trials was 150 milligrams. So this was the recommended dose from that trial based on these results. So moving on from this trial, there are some trials that are currently recruiting patients, and that also goes for the previous drug that I talked about, which are at the phase 2 or phase 3 level. So this means that there are trials that are much larger, they're recruiting a larger number of patients, and what they're trying to really look at is efficacy. So they're trying to see how well do these drugs work, not just in a few individuals that were included in the initial trials, but also in a larger cohort of patients. In this particular case, there are 2 trials which are currently open recruiting and are using this specific medication, the DCC-2618. One of them is trying to answer a simple question. So after you've had the first 3 lines of treatment that most people will go through, if as a 4th line, this is better to doing nothing at all. In this case, just by giving placebo. This is always a question worth asking because it doesn't go without saying. So here they're recruiting patients that have had 3 lines of treatment, imatinib, sunitinib, regorafenib, and then on progression, they're randomized to having a placebo or this drug. The very good thing about the trial is that it allows when you are on when you're on placebo only, when you progress, because you know whether you're having placebo or not, to actually be switched over and go to the other group where you can have the active drug and see what effect that has. This doesn't project as well as I hoped, but this is simply outlining exactly what I was telling you now. And it is important when trials allow this switch. So whether you're only on one active drug and the other is placebo, or whether you have 2 active drugs, whether trials allow what is called crossover. Now this trial is doing something which is slightly more ambitious, and what they thought is, well, this drug appears to be very promising, it worked very well in phase 1. Instead of looking as to whether it's helpful after 3 lines of treatment, can it actually be the drug that replaces sunitinib as a 2nd-line treatment? So after somebody has had imatinib on progression, could this be that this is what they go on to next? So this is, again, asking what is quite a simple question. On progression from imatinib, randomizing patients 1-to-1, half having sunitinib, the other half having DCC-2816. And again, crossover is allowed. So at the stage that somebody progresses, so if despite one or the other treatment the tumor grows, then they can switch to the other drug. And then in the end, of course, try and draw conclusions as to whether starting with DCC-2816 is better than starting with sunitinib or the other way around. Now, briefly about some other agents, because I know that I spent quite a bit of time discussing those, and they're very, very interesting. There's a lot more detail one can go into, because these things are complicated, especially as I'm sure that everyone who has been treated for this disease or has treated this disease understands that this is not just one tumor, and that's what makes it so complicated. So other agents that are currently being used, and all of them are still used in clinical trials and are not licensed at the moment. So pazopanib, this is a drug that has been used quite a lot in renal tumors. It has a slightly different mode of action, and so far it has been shown to be reasonably promising, although it hasn't been as promising as the agents I just told you about. Again, the majority of trials that use this are now recruiting, and in terms of toxicities, there's always the advantage that when you use an agent that has been used before in other tumor types, you've got a lot more experience as to what to expect. Crenolanib is another drug that has been used in trials, so far only in phase 1. This hasn't shown a great benefit, but again, what's really, really important, and that's something that can be understated, we are talking in the majority of these trials about people who have had lots of lines of treatment before. So this is not simply trying something from the very beginning. These are people who have had other lines of treatment. You saw in other cases up to 6 different kinds of drugs, and still when they have a new medication, they can respond to it. So then one could argue, well, this is a very small response rate, or why am I interested in a drug that will only help 3 of 10 people? Well, it's still very important, and especially if you can work out who is going to benefit and who isn't. Cabozantinib is another drug that is used in a number of tumors. It has been used a lot in renal cell cancers, and it is another drug that inhibits a number of different receptors, and this has also shown some promising results in GIST. Again, what I've been telling you applies. This is on patients that have had multiple lines of treatment before. Another advantage here is that we know the dose, we know the side effect profile, so everyone is a lot better prepared when they give this, even at the phase 1 setting. This is just an outline of how certain such trials work. Here we're not talking about a completely new agent, we're talking about a drug that has been given before. In other tumor types, there's a rationale behind giving it. So what they're trying to do in this particular trial is simply say, if with the first 41 patients that are treated, if 21 of them show that they have no progression in 12 weeks, great, we carry on. If they are not progression-free, so they progress within these first 12 weeks, there's no point carrying on with the trial. There are other drugs like MEK inhibitors that are also being used. Again, these are at the trial phase, but this I only included to make this point. Very often, especially in other tumor types so far, there's always the question, if you give one drug, you have specific results, and then you're hoping that by giving a subsequent treatment or one after that, that you will achieve even better results. Of course, there's always the question, why don't you give more than one drug at the same time? Especially when you know that you're targeting specific molecular pathways. What is known is that these pathways have many different elements to it. So one of the questions is, why don't you block 2 parts of the same pathway? And this is the rationale behind giving a MEK inhibitor together with imatinib. They work on the same pathway, but slightly further downstream, as it's called. So the question is, if you put them together, can you get even better results? Now, immunotherapy. There's always, well, certainly recently, there's been a lot of talk about immunotherapy, and immunotherapy has been called in many tumor types the next best thing, and in certain cases, it has changed completely the landscape of the treatment of these tumor types. In sarcomas in general, but also in GIST, this hasn't been the case. In GIST, there have been very few small trials that have tried immunotherapy, whether with one drug or combination. Here, what you can see is results from a very tiny cohort of patients either having nivolumab, which is one of the drugs commonly used and now has become standard of care in tumors like melanoma and is becoming in renal cell cancer, and also in certain cases where nivolumab and ipilimumab have been given together. And again, these are used successfully in a number of other tumor types like melanoma, non-small cell lung cancer, etc. Here the results haven't been as promising as they have been in other tumor types. So at the moment, these are being used with caution and also in the context, just in the context of clinical trials. So again, something that appeared to be promising in other tumors doesn't appear to be the case here. So in conclusion, I know that quite a few of these look quite complicated, but there are many new drugs that are now coming out for this disease. Quite a few of them are targeting areas that have been targeted before. So as I told you, the first 2 agents that I spent a bit more time on are drugs that are actually targeting the same receptors pretty much as imatinib, but because of the way they work, because of the concentrations needed and the spectrum of inhibition that they cause, are showing really, really promising results. And that is certainly so far the case in people who have been pre-treated with other medications. And then the new trials that are happening now and are opening, quite a few of them only opened this year, are trying to show, one, whether these are good at that setting, but also whether they can be moved further forward in somebody's treatment. So let's say right after imatinib. No one has yet been ambitious enough to try and displace imatinib from being the first choice. But I'm sure that if these trials are positive, somebody will eventually try to do that as well. There is a number of, well, as you saw, a number of other promising agents. Again, although sometimes you would argue that a lower response rate isn't very promising, something which is really, really important is that as we understand more about these tumors, as we understand more about the nature of mutations, it could be that in the future, this is not simply saying, you've had 2 lines of treatment, what is third? Or yes, this is the drug that is third, but hopefully be able to target specific tumors because of specific mutations if we can tell who is going to benefit from what the most. Something which remains very important is, respective of all these agents that are promising, and some of them are in phase 2 or phase 3 trials, what is always recommended and encouraged is certainly when somebody has had treatment, whether on or off trial, when it gets to the stage that they've been through the main drugs that can't be used, it's always encouraged that they take part in these phase 1 early clinical trials, especially when there's a rationale behind them. This is how new drugs come out. This is how we understand more about the tumors. And in fact, when there is such a thinking behind the drugs that are given, there are people who didn't have any further lines of treatment that were told that it's either this or what is called best supportive care. They went into a phase 1 trial, and now they can be presented in presentations like this with remarkable responses. So certainly participation in any trial, but even early clinical trials is encouraged. Thank you.